Ask everyone just to stand up and stretch real quick. It's always tough being one of the last speakers. Okay. Thank you. Raise the energy level a bit. I know we've all been sitting for a while. My name is Joel Milam. I'm from the University of Southern California. And today I'm going to be talking about post-traumatic growth among HIV patients, people living with HIV and AIDS. If you need to reach me, and if you have any questions during my talk, feel free to stop me at any time. But if you need to reach me, my email is my last name, Milam, at usc.edu. Just a quick background. Why look at HIV? Well, it's actually an excellent area to look at for examining the relationship between various protective factors and health. Frankly, because there's a large amount of variation in the disease progression that's unaccounted for. Even after you take into account these new powerful antiretroviral medications, there's still a lot of leftover variants. So any addition, anything that can potentially explain what else might be going on is valuable. And they're clinical indicators of disease progression. They're objective clinical markers that can be used to look at disease progression. And they're important health behaviors that are associated with the disease that we can look at. And finally, few investigators have actually looked at protective or positive factors in relation to disease. Normally, when you hear about studies about cancer or HIV or any life-threatening illness, you normally hear about what? Depression, distress, low levels of quality of life. But as Rich so eloquently presented, the whole concept of post-traumatic growth is that there can be benefits, there can be positive aspects to such a negative life event. So briefly, the aims of my study were the following: to determine whether people living with HIV or AIDS experience post-traumatic growth. Who knows, maybe this is a population where it doesn't occur. Secondly, to determine the correlates and predictors of post-traumatic growth. This is a longitudinal study over nearly a year and a half. So I was able to look at not only the time one correlates, but also see if there are any of those correlates remained in the longitudinal models to see if they were predictive of post-traumatic growth over time. And finally, and most importantly in my view, is to determine whether the experience of post-traumatic growth was associated with a disease adjustment adaptation over time. Now, I use disease adjustment rather loosely because it's actually encompassing a number of different factors. Disease status. And there are two clinical indicators of disease status that I use: viral load and CD4 count. And depression as another indicator of disease adjustment. Optimism, dispositional optimism, and pessimism are, well, optimism is well known in the health literature. It's one of the biggest protective factors that's looked at, aside from, say, social support. And that was one of the factors I was interested in. It was one of the focuses of the study, although the focus of my presentation today will be on the post-traumatic growth aspect. But I did hypothesize that optimism would be positively associated and pessimism would be inversely associated with post-traumatic growth. Previous literature indicates that females tend to report more post-traumatic growth than males, so I expected that. I also expected time since diagnosis, one's income, and religiosity to be positively associated with post-traumatic growth. Again, these are things that have kind of come up in previous literature, although recently the time since diagnosis has gone the opposite direction. But I anticipated that there would need to be some sort of rumination about, in dealing with the disease, that it might take time to even think about any positive aspects that can come from it. Some early previous research indicates that a correlate or possibly even another domain of the post-traumatic growth concept is positive changes in health behaviors. If one experiences positive changes in one area of their life, that might just spill over and also be associated with positive changes in another. And finally, I expected post-traumatic growth to be inversely associated with depression and disease progression. This study actually piggybacked on a much larger study, which was an intervention on HIV patients for medication adherence and safe sex. It was a rather large study. We recruited patients from 6 different outpatient clinics located throughout California. Inclusion criteria: at least 18, HIV positive for at least 3 months, English or Spanish speaking, receiving care at that clinic, and they had to be sexually active. And it was a pretty loose definition of sexually active, anything more than kissing. And here are some of the measures that we collected. The basic demographics. And for disease status, these were pulled from the actual charts. So we have CD4 counts and viral load to give you an overview of what these indicators are. So, your CD4 count is an immune system measure. And basically, you want higher levels. So when I present the data to you, lower levels mean that the virus has done more damage to the immune system, so low levels are bad. Viral loads, it's the opposite. High levels are bad. So a viral load is an indicator of how much virus is in the bloodstream, how quickly it's replicating. And these new antiretroviral medications suppress the levels of virus, so the viral loads drop dramatically once patients initiate these types of therapies. The health behaviors, these are one-item measures of exercise, diet, cigarette use, alcohol use, and illicit drug use. For depression, we used the CESD, and we excluded 5 somatic items similar to previous research with HIV patients, because these are associated with medication side effects and disease progression itself. But it was very, you can see the alphas there were totally acceptable for both time points, both over 0.90. For optimism, we used the revised life orientation test. Factor analysis indicated clearly loaded on 2 factors. Now, this is kind of recent in the literature where researchers are now splitting this measure into 2 different scales, one indicating optimism and one indicating pessimism. An example of an optimism item is, in uncertain times, I usually expect the best. And a pessimism is, I rarely count on good things happening to me. So it's an outcome expectancy. You either hold positive or negative expectancies for the future. And it's relatively stable over time. For post-traumatic growth, because we were dealing with a rather large sample and we had time constraints, we needed to limit the number of items. So we lifted some of the highest factor loadings from each of the subscales of the post-traumatic growth inventory. And each item was answered in response to what's occurred in your life since you were diagnosed with HIV. We also changed the response format. Since we didn't have all the items anyhow, we changed the response format to allow for negative changes because we were concerned that someone who was diagnosed with HIV would certainly experience some negative changes in a number of these domains. So we actually, the response format used was from 1 to 5, from highly negative change to highly positive change, with 3 being scored neutral. And beforehand, I declared a cut point of 4, meaning moderate positive change, to indicate post-traumatic growth. It was totally arbitrary, but it fits within the response scale format. But I looked at it as a continuous measure for most of the analyses. Yeah.
Would you have to change the wording on some of those items?
Correct. Right. Right. So the item, and I'll show that to you in a second. Appreciation for the value of my own life is how we changed it. So here's a brief overview of the analytical samples that we used. We screened over 2,000 patients. Of those, with the eligibility criteria, there's a little bit over 1,200 who were eligible for the study. Of those, we enrolled 886. Of those, 835 had complete data at baseline. So when I present a baseline analysis, these are the folks I'm looking at. I wanted to retain as much power as possible. We had consent to pull data from their medical charts. So for the biological outcome variables, we had a higher follow-up rate. So this box down here indicates 744 patients were used in the biological analysis over time. These folks were different from those at baseline. The ones who continued here, the ones who we had complete data with, had lower levels of depression, lower levels of pessimism, and those who were lost, those who completed had lower levels of depression, pessimism, and viral load. So they were doing better. So keep that in mind when you look at the differences. Only a certain number of folks responded to our follow-up, our complete follow-up survey. This is a problem with longitudinal data. We had a lot of trouble contacting a lot of these folks. But this sample here, this analytical sample, is really, there's only one difference between these two groups, and that is this group had lower levels of viral load, so they were doing better health-wise. Here's an overview of the sample. 87% male, the average age was 38, primarily white and Hispanic, but we had a pretty good distribution there. 17% African American, 37% Hispanic, nearly 40% white. Most were unemployed and on disability. And so this is a lower income producing sample, and a number of these clinics are through the county. So we're dealing with lower SES sample. Most of them have been living with HIV for a little bit over 6 years. So we had quite a good spread in years since diagnosis, and 46% had been diagnosed with full-blown AIDS. Nearly 80% were on these medications, the antiretroviral medications. The average CD4 count was 400. Now, a normal range for someone's CD4 count is 800 to 1200. In fact, if it drops below 200, that's an AIDS-defining condition. That's when there's enough damage to the immune system. The average viral load was 60,000. And that's relatively high. Anything over 50,000 is indicates a high risk for disease progression. The mean post-traumatic growth score, now remember this is on a scale of 1 to 5, was 4.1. So on average, the study participants indicated moderate positive changes since diagnosis. This was quite surprising. In fact, that represents about 59% of the sample scoring, had a mean of 4 or greater at time 1, 55% at time 2. And supporting that positive-negative response format, 9% of the sample at each time point scored less than 3. So there are nearly 10% of the sample indicating negative changes on these different domains. I guess one more thing to point out was the optimism score was also quite high. The mean was 10, and that's the range there goes up to 12. So despite poor health, despite low income, these folks are endorsing these positive items. They're relatively optimistic and endorsing the post-traumatic growth items. In fact, let me just show you the items, post-traumatic growth items we used. This is at baseline, and this shows the range of 81%. This is 4 or greater, so moderate positive change in this area or greater, indicating positive changes in priorities about what they think is important in life. And the lowest endorsed item was my religious faith. Only 48% indicated positive changes in their religious faith.
I have a question about
Yeah.
questions, and I think it relates also to the actual PTGI, and maybe Dr. Calhoun might be better suited to answer this question. But I'm wondering, he's not here. I'm sorry about that. Why were only 2 items chosen for the spiritual factor? I know that you actually changed it, but I noticed you didn't keep both of the spiritual factor items. And there seems to be a distinction between the 2 items, indicating that maybe the alpha might not be as high as some of the other factors. Why is it that factor only has 2 items, whereas the other factors seem to have more variety of questions?
That's simply empirically based on the original study. We had 34 PTGI items, and we subjected it to factor analyses and internal consistency, and chose the ones that showed the greatest relationship with the total score. And the way the factor analysis worked out, that's what we got. There were 2 items on the spiritual development.
The items in this study tended to load on a single factor. We pulled at least 2 items from each factor, but they tended to clump together. Here are the correlations at baseline between the major variables of post-traumatic growth. Here, there's an inverse correlation, which I didn't expect between years since diagnosis, but it's actually consistent with the more recent literature. No relationship with CD4 count, either at baseline or over time. There's an inverse association between post-traumatic growth and viral load at both time points. And post-traumatic growth was associated with all the health behaviors, although the exercise and diet relationships weren't that strong, but they were consistent with my hypotheses. And with the psychological variables, they all fall into place as expected, inversely with depression and pessimism, and positively with optimism. And the time 1, time 2 correlation with post-traumatic growth was 0.41, there at the bottom. So first, with the regression analyses, I'd like to present the post-traumatic growth regression analysis. This is simultaneous regression, looking at post-traumatic growth at time 1 and time 2. And what's striking, if you look between the columns, is there's a lot more to talk about at time 1 than there is at time 2. At baseline, there's an inverse association with age. Here we see that females tend to report more post-traumatic growth than males. Income was not related. African Americans and Hispanics tended to report more post-traumatic growth than whites. And here we see the health behaviors. Alcohol use and eating a healthy diet remained after adjusting for all these other factors. Depression and pessimism remained as inversely associated in this model. And optimism was positively associated in this model. So a good portion of those relationships held up after adjusting for one another and disease status. However, over time, I didn't mention religiosity. We threw that in at time 2. We didn't have it at baseline. And this was a very, this was a simple measure, dichotomous yes, no. So participants were coded as religious if they were either currently attending religious services or a member of a church, synagogue, or other place of worship. And that, so that's a cross-sectional relationship there. Over time, those who were depressed experienced less post-traumatic growth or decline in post-traumatic growth over time. Now, the relationship between depression and post-traumatic growth is a tricky one because post-traumatic growth did not tend to predict depression over time. So this preliminarily, it's looking like depression inhibits post-traumatic growth. Now, there's previous literature that suggests that it's the change in post-traumatic growth that has more of an impact on distress or depression. So to get an idea or to get a look at this, I used, that same cut point of 4, and I created some subgroups. And this actually played out rather nicely. This is depression here, the depression scale on the y-axis. And here we see those who never experienced post-traumatic growth had the absolute highest levels of depression over time. Those who gained post-traumatic growth had a decrease. And those who always experienced post-traumatic growth had the absolute lowest levels of depression over time. Whereas those who lost post-traumatic growth had an increase. And this difference between this group and these two groups down here is significant. So this indicates that there's a possibility that experiencing changes in benefits can either inhibit or facilitate depressive symptoms over time. Here's a regression analysis of viral load over time. Here we see post-traumatic growth is unrelated to viral load, although pessimism was. Those who were more pessimistic had higher levels of viral load over time. So those who held these negative outcome expectancies, it's kind of a self-fulfilling prophecy, experienced negative health outcome. Now I added two-way interactions between optimism, pessimism, these demographics, and post-traumatic growth in a second step to this model. And there was a significant interaction between post-traumatic growth and pessimism. such that among those who did not expect negative outcomes in the future, those with low pessimism, there was a relationship between viral load and post-traumatic growth. So those who did not expect negative outcomes and experienced or perceived benefits from their situation had lower levels of viral load compared to those who did not. And that's a median split on pessimism. So this is quite interesting, suggesting that it's not just perceiving benefits, but it's also not anticipating future negative outcomes that combined appeared to have a positive impact on a biological indicator of health.
But the difference is not that where
this is a log transformed, so it's actually almost a complete log, one log difference, which would be a 10 times. So for it actually, yeah, and that one is actually quite a big difference. But for CD4 count, again, there's no relationship over time with the psychological variables. And here, you know, the size of the difference might, here that criticism actually might hold up. Because these differences aren't huge, but I would argue that if, I mean, a CD4 count is something that's closely watched, and so a 50-point drop is enough to raise someone's level of awareness, like, whoa, what's going on? Are my meds not working? Do I need to change my lifestyle? And here we do see, you know, nearly 50-point differences. But what I wanted to point out here was there's an interaction with ethnicity and post-traumatic growth in predicting CD4 count over time. What's odd is here you see a positive relationship between post-traumatic growth and CD4 count for all the ethnic groups except for whites. And because whites were the reference group, the interaction was with Hispanics. And this is a confusing interaction and one I haven't been able to tease apart. But I do know that it's not due to acculturation because we use language as a proxy, although that's a crude proxy. It didn't solve it. Health behaviors didn't explain it. Mode of transmission didn't explain it. So I'm still working on that one. I'm running low on time. That's why I'm going real fast right now. I'm going to skip that interaction. I want to give you a chance to talk. Let me just go straight to the discussion and go over a few points. First, post-traumatic growth was common. Nearly 59% at baseline endorsed those items. Post-traumatic growth was associated with low levels of viral load, although that was primarily among those low in pessimism. Post-traumatic growth was associated with high CD4 count over time. But again, that was primarily among Hispanics, and the other interaction I didn't show you was moderate levels of optimism. Post-traumatic growth the changes in post-traumatic growth was associated with less depressive symptoms. And at baseline, more health behaviors. But the process of post-traumatic growth is unclear. It may occur suddenly. There was that inverse association with time since diagnosis. We did exclude those who were more recently diagnosed, so it's beginning to look like it can occur quite suddenly, and early in the disease process. Over time, only depression and religiosity predict post-traumatic growth, and you know, these interactions definitely need replication. I'm going to skip those and just... Interventions will benefit if they address life perception, positive reframing of negative situations, and future orientation. I think simply bringing up the topic or the possibility of post-traumatic growth, Dr. Tedeschi talked about this, could have an impact. I also think one strategy for intervention research is selectively targeting pessimists or those who score low on post-traumatic growth would be an effective strategy. So that's whiz-bang quick review of the post-traumatic growth findings in my study, and I appreciate your attention.
I'll just speak for a few minutes to comment on this area. In the last 2 years, we've been working on tragic optimism, which is very paradoxical because a person who is high on tragic optimism is both pessimistic and optimistic. Okay, one is pessimistic about the life situation, but optimistic about the future, about life itself. Okay. Now, this kind of optimism can endure the worst kind of horror, the worst kind of trauma. It's kind of optimism for people in Middle East, Palestinians, okay, in Africa, who daily face death and destruction. And how can they expect good things to happen tomorrow or good things to happen usually? How can they say, oh, I have the competence to achieve my goal? 80% people in a refugee camp are employed. So I just imagine, you give the scale a lot or hope, give to those people, how would they feel? So we have developed the kind of tragic optimism, which basically have 5 elements. The first one is affirmation, affirming the intrinsic value of life, regardless how difficult it is, affirming that positive meaning can be found even in the worst kind of situations. That affirmation. The second one is acceptance, accepting that life is hard. Accepting life is unfair, accepting the situation is very bleak, accepting my vulnerability, my limitations. The third one is faith. Even when everything else fails, God may come through for me. Even though everything is unfair, there will be ultimate justice. There will be ultimate meaning. For many people, faith is the only candle in an otherwise dark world. The faith. Now these three things, acceptance, affirmation, and faith, will help to restore shattered assumptions. And if you have all these 3 things, you'll be more resistant to trauma. The fourth thing is self-transcendence, which means because your own pain, your own suffering, you're willing to reach out to help other people. Compassion, okay? That life is not just revolving around yourself, but you want to make a difference in the world. And fifthly, courage. That you're willing to move forward. You're willing to face tomorrow, even though tomorrow life might be tough. That you're willing to persist to pursue your goal in spite of suffering and obstacles. So these 5 elements correspond to your 5-area growth. For example, affirmation is related to appreciation, also Bob's gratitude, right? And acceptance is vulnerability, and faith is spiritual growth, and self-transcendence related to relationship, reaching out. And courage is related to what the last one. Pursue new possibilities, right? So we're predicting that people who have tried optimism will be more likely to show post-traumatic growth. And also in intervention, if you bring these 5 elements, you facilitate post-traumatic growth. Now, for your interest, young man, we found that tragic optimism is not correlated with lot. is not correlated with hope, but correlated with highly with meaning and spirituality and religiosity. And I'll bet you anything that the TO is much better predictor of trauma, post-traumatic growth than either pessimism or optimism. Thank you very much. Okay, we are going to